from chapter 15 on the autonomic nervous system. Involuntary organs like the heart are supplied by both divisions of the autonomic nervous system, which are the sympathetic division and the parasympathetic division. So since the sympathetic division is the fight or flight division, sympathetic stimulation of the heart tends to speed up the heart rate. Okay? You speed up the heart rate, then that increases the amount of blood that's pumped per minute, and that supplies the body with more oxygen and nutrients. The parasympathetic division does just the opposite. So with parasympathetic stimulation, that's going to slow the heart rate down. Now, the parasympathetic division affects mainly just the heart rate. The sympathetic division, on the other hand, increases both the heart rate as well as contractility, which is the strength of the contraction. Okay, if the heart contracts stronger, it's going to eject a greater proportion of the blood that fills the ventricles during diastole, which is the phase of ventricular filling. So the reason for that is probably because there's sort of an inverse relationship between heart rate and stroke volume, which is the amount of blood that's pumped by the heart with each beat. The faster the heart beats, the less time the ventricles have to fill with blood. And as we'll learn a little bit later, there's a direct proportion between, there's a direct relationship between the amount of blood that fills with the ventricles and the amount of blood that's pumped with each cycle. So the more blood that fills the ventricles, the more blood that's going to be pumped by the heart. Okay. But so if you increase the rate, that's less time for the ventricles to fill. There's going to be less blood in the ventricles, and so less blood will be pumped out. So that's going to kind of counteract the effects of increasing the heart rate. But if you increase the heart rate and increase the strength of the contraction, then both of those are going to help to provide more blood to the body. So it won't affect the amount of blood that's pumped by the heart so much. Okay. Now, as it turns out, the SA node, which is the pacemaker of the heart, is mostly on the right side of the heart, in the wall of the right atrium. That happens to be the side of the heart that's supplied by the right vagus. The vagus nerve is located, it runs down from the brainstem along both sides of your neck. There's one on the right side and one on the left side, and then it continues down into your chest, and the right vagus supplies the SA node, which is the pacemaker of the heart. So right vagal stimulation actually affects the rate the most. The left vagus nerve supplies the AV node, but ordinarily the AV node does not determine the rate of the heart. It's the SA node. So left vagal stimulation generally doesn't affect the heart rate very much. Now, it's probably not going to make much of a difference in most situations, because normally the amount of left and right vagal stimulation are going to be about the same. The only situation I can think of where that might be different is either artificial stimulation or experimentally, or if there's an injury. If there's an injury to one side of your neck, it could affect one side, not the other. But and there's little or no vagal stimulation of the myocardium, because that's not what affects the rate of the heart. That wouldn't affect the function of the heart really in any way. All right, so on Friday we went through the conduction system of the heart, which starts with the SA node, and then it goes from the SA node to the atria, causing the atria to contract. and complete the filling of the ventricles with blood. Then the signals stimulate the AV node, which sends out signals via the atrioventricular bundle, which goes down partway through the interventricular septum. Then you have the right and left bundle branches that go down the rest of the way down through the interventricular septum. And then finally you have the Purkinje fibers that supply the walls of both ventricles. And those signals get to the ends of the Purkinje fibers. That causes both of the ventricles to contract at the same time. So the so-called cardiac cycle is defined in terms of ventricular contraction and ventricular relaxation, because it's the ventricles of the heart that do most of the pumping. The atria are mostly just receiving chambers, and they only contribute a relatively small part to the total volume of blood that fills the ventricles. So we define the cardiac cycle in terms of ventricular contraction and relaxation. The phase of ventricular contraction is called systole, and the phase of ventricular relaxation is called diastole. Okay? So if you just hear the terms systole and diastole, you have to assume that we're talking about the ventricles. Okay? Now, you can talk about atrial systole and atrial diastole, but you have to say that. You have to say atrial diastole or atrial systole if you're just referring to contractions and relaxation of the atria. Otherwise, you have to assume that we're just talking about the ventricles, which is really the most important part of the heart, because that's the part of the heart that pumps the blood. Why my clicker's not working for some reason. Yeah. Try switching this. Let me switch the view I have on my screen here. All right. Okay. So normally the heartbeat is triggered by the SA node, because that's the pacemaker of the heart. And generally that causes the heart rate to be anywhere between 60 and 100 beats per minute, depending on the person. Okay, there's a lot of variation. Normal is probably around 70, 75 beats per minute. That's probably about average. But can range anywhere from 60 to 100 beats per minute. So the typical heart rate is 70 to 80 beats per minute. That's called the vagal tone. Okay, that's due to the amount of vagal stimulation at rest. All right. Now there's a abnormal situation that can occur sometimes due to either hypoxia, which is a lack of oxygen, or electrolyte imbalance, or due to drugs like caffeine or nicotine or other drugs. It's called an ectopic focus. What an ectopic focus is it's a part of the ventricular wall that for some reason will spontaneously depolarize on its own. Now, any parts of the ventricular wall can spontaneously depolarize on its own. However, the rate of spontaneous depolarization of the contractile cells in the ventricles is very, very slow. Normally, it's so slow that the signals that are traveling down the conduction system cause those contractile cells to depolarize first before an ectopic focus ever has a chance to develop. Okay. However, if a person has had too much caffeine or too much nicotine or some other substance, or if their heart is deprived of oxygen, then it may cause a part of the myocardium to spontaneously depolarize. And if that happens before the ventricles are stimulated to contract, that may cause what's called a preventricular contraction. And down here in the lower right is a recording of electrocardiogram. And normally when the ventricles depolarize in response to the signals traveling down through the conduction system of the heart, you see a large spike, a very sharp spike on the electrocardiogram. It's that largest spike you see on there. But if an ectopic focus occurs, which causes electrical signals to travel out to the walls of the ventricles from a different point of origin, then you may see a big dip on the electrocardiogram. Okay, that represents an ectopic focus, or that represents what's called a preventricular contraction, because part of the ventricles are contracting prior to the normal systole. Okay, and if that's just because somebody's had one too many cups of coffee during the day, it's usually not a major problem. Sometimes people sort of notice when it happens because it'll feel like their heart is skipping a beat, because there'll kind of be a long pause after a preventricular contraction. But it usually doesn't cause too many problems unless it happens too often. If it happens too often, it can actually throw the heart out of its normal rhythm, and it can cause the ventricles to go into what's called ventricular fibrillation. And that's when you sort of get a positive feedback cycle in the ventricles, where you'll have signals going out from an ectopic focus that will cause another part of the heart to depolarize, and those signals go back to the ectopic focus. And what will happen is the ventricles start contracting asynchronously. Like different parts of the ventricles will contract at different times. And if that happens, then the ventricles aren't able to contract as one, and the heart won't be able to pump blood. So ventricular fibrillation is very, very serious, because basically when the heart is in ventricular fibrillation, it's not beating. The heart is not pumping blood. And so if that happens, then that person needs to have intervention right away, within a few minutes. In fact, what you need to do is start CPR right away, because the heart's not pumping blood the way it should. So what do you do when the heart goes into ventricular fibrillation? How do you stop that vicious cycle from happening? What do you do besides giving them CPR, because their heart's not beating properly, to get them out of ventricular fibrillation?
Would it be like an AED or something?
Yeah, you have to use an AED, an automatic external defibrillator. Okay, a defibrillator is a device where you put electrodes on the person's chest, and it gives them a very large shock, with fairly high voltage. What a defibrillator does is it depolarizes the whole heart at once, so it can kind of get restarted again and get back to a normal rhythm. Sometimes it will work the first time. Sometimes it takes more than one try. Okay, but sometimes, not always, but sometimes that'll get the heart back into its normal rhythm again. If it doesn't, then you need to give CPR until you can get them to a hospital, because if their heart stops pumping blood, their brain is going to be deprived of oxygen within just a few minutes, and brain cells are going to start to die. So it's really important. It's really important to get that blood circulating again. All right, now another problem that can occur is if a person has a myocardial infarction, which is a heart attack, in the part of the right atrium that contains the SA node. If that were to happen, then the SA node may not function properly. And so then an ectopic focus might take over control of the heart rhythm, which would cause the heart rate to be a lot slower. So if the SA node is damaged, what usually happens most of the time is the heart rate is then set by the AV node, because the AV node also spontaneously depolarizes, but it spontaneously depolarizes at a rate that's slower than the SA node. So normally the SA node depolarizes the AV node before it's had a chance to spontaneously depolarize. But if the SA node is not functioning, the AV node will take over. It'll send out signals, but at a rate that's slower than the SA node does. And that's called a nodal rhythm if that occurs, instead of a sinus rhythm. If the SA node is functioning as normal, that's called a sinus rhythm. So typical resting heart rate would be 70 to 80 beats per minute. Nodal rhythm is going to be a lot slower. It's going to be 40 to 50 beats per minute, which is about the range of a really highly trained endurance athlete. Okay, so just because you have a slow heart rate doesn't necessarily mean that you have a nodal rhythm. It could be that you're just really fit, and your heart is working a lot more efficiently than most people. Now, if both the SA node and the AV node fail to function, then the ventricular cells will eventually, they will eventually spontaneously depolarize, but they only do so very, very slowly. And so that would cause a person to have what's called an intrinsic ventricular rhythm. That's very, very slow. That's anywhere from 20 to 40 beats per minute. And that's really too slow to meet the demands of a person's body. So a person that has an intrinsic ventricular rhythm really needs a pacemaker to increase the heart rate so that their body's going to get enough oxygen. Now, there are conditions that affect the conduction system of the heart that can result in what's called an arrhythmia. An arrhythmia is any abnormality of the cardiac cycle caused by a failure of part of the conduction system. And that could be because there's damage to a part of the interventricular septum where one of the bundle branches is located, or it could be damage to the atrioventricular bundle that would prevent electrical signals from getting from the upper part of the heart to the lower part of the heart. Now you can detect arrhythmias, and we'll take a look at some examples of some different types here in just a little bit, but you can detect cardiac arrhythmias, which indicate damage to the conduction system of the heart, by doing an electrocardiogram, which actually happens to be what we're going to do in lab this week. We're going to do a lab involving an electrocardiogram. Now, you do an electrocardiogram by placing electrodes across the heart, on either side of the heart. It can be in any direction across the heart. And if you do that, the electrical signals that are produced by the heart are also conducted through your body wall all the way out to your skin. So if you put electrodes in your skin, you can record those signals that are produced by the heart. And what you see up here are parts of two different cardiac cycles. So this represents two different cycles of contraction and relaxation of the ventricles of the heart. So on a typical cycle, there are three different waves that you can see on an electrocardiogram, assuming it's normal. The first wave that you see on the far left over here is called the P wave. The P wave is electrical activity that's produced when the atria are stimulated to contract by the activity from the SA node. So the P wave represents those electrical signals going out from the SA node, causing the atria to contract simultaneously. Then there's a very larger signal. It's called the QRS complex. The QRS complex represents the electrical activity that goes down into the ventricles, causing the ventricles to contract. So QRS complex is a measurement of the ventricular depolarization that stimulates systole, which is ventricular contraction. And it's a lot higher because there's a lot more muscle mass in the ventricles. So the total amount of depolarization is a lot larger in the ventricles. And the third wave that you see on electrocardiogram is called the T wave, which usually is a little bit larger than the P wave. The T wave represents ventricular repolarization. That's when the ventricles are repolarizing. That would occur during diastole. Okay. Now, there should be a wave for atrial repolarization. However, atrial repolarization occurs at the same time that the ventricles are depolarizing. So the wave for atrial repolarization gets hidden by the QRS complex. Okay. So if you see those three waves, what that means is that the atria are depolarizing, that's your P wave, causing the atria to contract. And then the QRS complex means the ventricles are depolarizing normally, and the ventricles are contracting. And then the T wave means that the ventricles are repolarizing, so it's ready for another cardiac cycle again. Okay? So that's what you should see on a normal electrocardiogram. Now, so that's what you see here in this recording on the upper left. Okay, that's a normal, what's called a sinus rhythm. Okay. Now, if the SA node is not functioning properly, if the SA node is not spontaneously depolarizing because maybe it's damaged, then you won't see a P wave in front of each QRS complex, because that means the atria are not depolarizing. Now, nodal rhythm is not an immediate life-threatening problem because blood can still fill the ventricles without the atria contracting. Because over half of all the blood that fills the ventricles does so before the atria contract. The blood fills the ventricles when the ventricles start to relax and the volume of the ventricles increases, causing the pressure to drop. And that, when the pressure in the ventricles falls below that of the atria, then blood flows passively from the atria down into the ventricles. That's called passive filling. That occurs right before atrial systole. So the heart could still pump blood because it's not the atria that do most of the pumping, it's the ventricles. As long as the ventricles keep contracting, the heart can keep pumping blood. It's not the best situation though, because if the atria aren't contracting, then some blood can pool in the atria that could increase the chances of blood clots forming in the atria. And if one of those blood clots break loose and goes down into the right ventricle and then up through the pulmonary trunk, that could cause a pulmonary embolism, which would prevent the blood from getting oxygenated in the blood. So people that have whose atria are not functioning properly, like an atrial fibrillation, they sometimes have to take blood thinners so that they don't get blood clots in the atria. But this is an example of a nodal rhythm. That probably means that person's going to need to have a pacemaker, if you see that. Now, another problem you can diagnose using electrocardiogram is heart block. And there's different degrees of heart block. Sometimes the signals are initiated on the SA node are prevented from going all the way down to the ventricles because part of the conduction system is not working the way it should. If it's only partially damaged though, sometimes with one cycle the signals may not be able to make it down to the ventricles, but the next time it might. So the ventricles may only contract maybe every other time that the SA node sends out signals. Or sometimes the ventricles will only contract every 3 times the SA node depolarizes. And so that would result in what's called heart block. So this is an example of heart block. So here you have one normal cardiac cycle where you get atrial depolarization followed by ventricular depolarization. But then we have a P wave that's not followed up by a QRS complex. That means that those signals from the SA node aren't able to go all the way down through the interventricular septum. Something is preventing them from continuing on down towards the apex of the heart. And so if those signals don't cause ventricular depolarization, the SA node will send out signals again, and again, we have no QRS complex after that. But the third time, signals might make it through to the ventricles. So then we have a normal, QRS complex or a normal ECG recording. So this is an example of heart block, and they have different degrees of heart block. There's 2-to-1 heart block, where the SA node depolarizes twice before the ventricles contract. Sometimes there's a 3-to-1 heart block, or if you have total heart block, then the signals aren't making their way down the atrioventricular bundle and the bundle branches at all. If a person has total heart block, then the ventricles eventually will spontaneously depolarize, but your heart rate's going to be very, very low, like around 20 to 40 beats per minute, and that's definitely a problem. Okay. Then the one that's in the middle on the right-hand side, that's an example of a premature ventricular contraction, or PVC, as they're frequently called for short. That is caused by an ectopic focus in the ventricles. That could be either a sign that a person has electrolyte imbalance, or they've had too much caffeine or nicotine, or it could be because part of the ventricle wall is damaged, like a person had a myocardial infarction and survived, but that part of the heart is not functioning right, causing it to spontaneously depolarize. Most of the time, it's just something happens every once in a while, and it's no big deal. Usually, it's someone's had too many caffeinated drinks. One time when I was demonstrating how to do a 2-lead ECG in lab, I threw a PVC. It was the first time I'd ever seen one. I was all excited. Oh wow, look at that. Probably because I had too much coffee, because I usually drink a whole pot of coffee during the day. Now, if you see something looking like that recording on the bottom right, that's very, very serious. That's what ventricular fibrillation looks like. So what happens in ventricular fibrillation is signals are being spontaneously generated by a part of the ventricular wall, possibly because the heart's not getting enough oxygen, because the blood flow to the heart is being cut off. And if that can kind of set up a positive feedback cycle in the ventricles, causing different parts of the ventricles to contract at different times. And since the heart can't contract in unison, it's not able to pump blood. So basically, when a person's heart is in ventricular fibrillation, they're in cardiac arrest. Their heart's not pumping blood, and you need to use an AED, an automatic external defibrillator, to defibrillate them, or you need to immediately start CPR and get them to the hospital as soon as possible. So most of the time when that happens, unfortunately, odds are the person's not going to be able to make it. Most of the time, even if you do CPR and do everything properly, if their heart has stopped, within a few minutes, their brain's going to start to be deprived of oxygen. There's really not a whole lot you can do. There's probably only maybe 10% chance the person's going to survive, but there's a chance. So it's a good reason to start doing CPR and do what you can for them. All right, any questions? All right. Now, this inherent rhythm, this spontaneous depolarization that occurs in the pacemaker cells is due to what are called pacemaker channels that allow sodium to slowly leak into the pacemaker cells. Now, these pacemaker channels are very unusual. In fact, at one time, physiologists referred to that slow influx of sodium, which causes slow depolarization. They called that a funny current, and they called those pacemaker cells, those pacemaker channels that did that, they called them funny channels because they were exhibiting really strange behavior, because basically these pacemaker channels are activated due to repolarization, and well, actually, it's a hyperpolarization. They're activated when the membrane repolarizes and then becomes hyperpolarized, and then they slowly open up and they slowly allow sodium to leak in, so the membrane potential slowly rises. Once they hit a threshold, then those pacemaker cells undergo what's called a pacemaker potential, which is a type of action potential. So this pacemaker potential is due to 3 different ion channels that are in the membrane of these pacemaker cells. They have one ion channel that's unique, and that's the pacemaker channels that are activated in response to hyperpolarization. So after the membrane has hyperpolarized, those pacemaker channels open up. It allows very slow influx of sodium, which causes the membrane potential to slowly rise. When the membrane potential hits a threshold, that causes calcium channels to open. These calcium channels, though, are very, very slow. They don't all open all at once like sodium channels do. They open very slowly. So the depolarization phase of the pacemaker potential takes place over a much longer period of time than action potentials do, for example, in neurons or in skeletal muscle fibers. So the second ion channel are slow calcium channels, causing a relatively slow depolarization. Once the membrane depolarizes, then there are slow potassium channels to open. Slow potassium channels open. When the potassium channels open, that causes the membrane to slowly repolarize. Once the membrane hyperpolarizes, then the pacemaker channels open again, and those pacemaker channels then allow a slow leak of sodium through the membrane, causing this very slow upstroke of the pacemaker potential. Okay, so the first step in the pacemaker potential is that the pacemaker channels open. Okay, these pacemaker channels are called hyperpolarization activated cyclic nucleotide gated channels. That's the full name of them. And there's 4 different kinds. The type of pacemaker channels found in the SA node cells are called HCN4 channels. They allow sodium to leak in faster than other HCN channels in the heart, like the ones in the AV node or the ones in the ventricular cells. Ones that allow so these pacemaker channels are found in all of the cardiac muscle fibers in the heart, but the ones that are in the contractile fibers in the ventricles only allow the sodium to leak in very, very slowly, so slowly that they ordinarily are stimulated by the signals that are initiated from the SA node and the AV node. So the first ones that open are the pacemaker channels. That allows a slow influx of sodium. Then once the depolarization starts, then the pacemaker channels close. Then the calcium channels open. Calcium slowly diffuses into the cells because calcium is always in a higher concentration in the extracellular fluid. So you get an influx of sodium that depolarizes the pacemaker cells. Then, once the membrane has completely depolarized, calcium channels close and the potassium channels open. When the potassium channels open, you get a very slow influx of potassium, which repolarizes the membrane fairly slowly, though, not very quickly. And then once the membrane becomes hyperpolarized, the potassium channels close, and the pacemaker channels then open again. Okay. So there's 3 channels that are responsible for the pacemaker potentials. Okay, so that's what determines the rate of the heart. Now let's take a look next at what an action potential of ordinary contractile fibers looks like in the heart. Okay, this is a graph. This green. Notice the green line. This green line represents the action potentials of contractile fibers in the heart. Okay. Now there's also 3 different channels involved in the action potentials of the contractile fibers, which are the ones that contract in response to depolarization. The first one, however, is different. The first ion channel are fast sodium channels. So when a contractile fiber gets stimulated by a signal from either the SA node or the AV node, whichever the case may be, that activates fast sodium channels. Those sodium channels start opening very quickly. That results in a very rapid depolarization. Just kind of like the depolarization phase of neurons or skeletal muscle fibers. Once the membrane has depolarized, then the slow calcium channels start opening. Now the slow calcium channels not only open slowly, they also close very slowly. So the fact that the calcium channels stay open for an extended period of time means that the membrane can't repolarize. Even after the potassium channels start opening, they can't repolarize because the calcium channels are still open. The calcium is still diffusing inward. So in cardiac muscle fibers, or the contractile fibers, there's a very long plateau phase. And while the contractile fibers are in that plateau phase, there is an absolute refractory period. So that means that cardiac muscle fibers have a very, very long absolute refractory period during which that cell cannot be stimulated again, even by another depolarization. Now, this very long absolute refractory period caused by this long plateau phase is very important, because what it means is that you cannot have summation of cardiac action potentials. Because if you did get summation of cardiac action potentials, then those muscle fibers would contract and they'd stay contracted. They'd be in tetanus. And if the heart contracted and stayed contracted, it wouldn't be able to pump blood. Okay? So the fact that there is a very long plateau phase means there's a long absolute refractory period. It means that the heart cannot go into tetany, where it stays contracted. Because if it did, the heart would be in cardiac arrest. The heart wouldn't be able to pump blood. So after this very long plateau phase, the slow calcium channels do eventually start to close, and then slow potassium channels open. And once the calcium channels start closing and the potassium channels start opening, then the heart muscles, or the heart muscle fibers, are able to repolarize again. Okay? So you get a very rapid depolarization caused by opening of fast sodium channels. Then you get an opening of slow calcium channels that stay open for a relatively long time. Then they start to close, and then the potassium channels, the slow potassium channels, begin to open. And that allows it to repolarize. Okay. So you got three different ion channels involved, but they're not exactly the same as the one, especially the first one. The first one is completely different. The one in the pacemaker cells are the pacemaker channels, the HCN4 channels. The first ion channel involved in the contractile fibers are sodium channels. Okay. All right, any questions? All right, so let's do a review question next. Okay, one of the things that physicians sometimes give to patients that have high blood pressure is a drug that's called a beta blocker. Now, beta blockers block the beta receptors on the heart, which normally are stimulated by norepinephrine. Norepinephrine is released by the sympathetic postganglionic fibers. So that causes an increase in the heart rate and the strength of contraction. But beta blockers, beta blockers block those receptors. So that prevents the norepinephrine from binding. And so that's gonna slow down the heart. And when the heart slows down, that's gonna help to bring down blood pressure. Okay. So the question is, the administration of beta blockers to the heart would primarily affect which division of the autonomic nervous system? Beta blockers were the first type of blood pressure medication that was used. They now have other kinds that block other kinds of ion channels, like calcium channels. They have calcium blockers. Some people can't tolerate beta blockers. The problem with beta blockers, they affect other organs as well. All right, well, my description of what happened here probably gave away the question, so let's take a look at the results. Majority of you said sympathetic division, and that's correct. Okay, the norepinephrine is released by the sympathetic postganglionic fibers that ordinarily binds to beta receptors, if you administer a beta blocker, that's going to prevent norepinephrine from biting. So that'll slow down the heart. If you slow down the heart, that decreases cardiac output. If you decrease cardiac output, that decreases blood pressure. Okay, so administration of beta blockers to the heart would cause the heart rate to do what? Would it increase or decrease? Okay, I already gave you the answer, so you already know then that it would slow down the heart. All right, so that should give you a lot to think about, okay? So what we're going to do next is, now that we have seen how the electrical activity of the heart spreads down through the heart, what we're going to do now is we're going to look at some of the details of what's called the heart cycle, which is the alternation of contracting and relaxation of the ventricles. All right, any questions? Oh, just a quick reminder, we are going to have a quiz this week in lab. We're going to have one over how to write a research paper, okay, that we went over last week. So just study that information that I put on Canvas that we went over last week on how to write a lab report. Okay?